All right, ladies and gentlemen, I am so excited to introduce to you my friend Tosha Kozloski. Tosha is a dental hygienist, is a visionary behind TOSH, which stands for Teaching Oral Systemic Health. As a dental consultant and educator, she's dedicated to transforming the dental paradigm from reactive to proactive. Leveraging her experience in microscopy and salivary diagnostics, Tosha equips dental teams to gain a deeper understanding through visualization, inspiring clinicians to be more informed about infections, and fostering a culture of holistic patient care. Through her own innovative approach, practice owners establish a wellness-focused hygiene department, and it is my pleasure. I love the phase contrast microscope. It changes everything. Once you see it, it sells itself. So enjoy my friend Tosha.
Thank you, Barbara. The master microscope herself. All right, friends. Let me shift this over here. Thanks for spending your afternoon after, I'm sure, a very long and exciting day. So what I'm going to be talking to you guys about today is really just using a phase contrast microscope and the benefits that it can have for the practice. And so I call this optimizing oral wellness. Chairside microscopy is the main focus here, and we can't really start it without talking about the father of microscopy, Dr. Paul Keyes. As you guys can see here, he lived to be nearly 100. He only died 3 months shy of his 100th birthday. And fun fact, his wife actually lived to be 101, which is pretty awesome. And so I really consider him, and I think everyone else does, the father of microscopy. He is really who started all of this. And he was the first in 1946, to identify that there was something to do with the bacteria and plaque that was breaking down gum tissue. And then in 1976, he was among the first to start using antimicrobials and then also using saliva testing chairside for his patients. And so what he really wanted was a paradigm shift in the way that we diagnosed and treated periodontal disease, really veering from just waiting for pocket depths and bleeding points and starting to use microbiological testing, the microscope. And so he called his technique MMPT, modulated microbial periodontal therapy. So it's really much the same as what we're doing today, that intense medical dental exam, looking at what makes that patient individual. But then on top of that, he would just simply take a microscope slide to see if there was any pathogenic bacteria that were associated with gum infections and gum disease. And so if he did find bacteria, then he would use antimicrobials and follow that patient through therapy with taking a slide each time, with the overall goal being decreased volume, decreased motility of those pathogenic bacteria. And so he stated in 1982 that it soon became apparent that there were striking differences in the prevalence of white blood cells and their microorganisms and their patterns of organization. So on the slides here on the left-hand side, they're all more frantic looking. So what Dr. Keyes really realized was that when you started to see those frantic slides, lots of volume, high motility, those were signs that the patient had very dysbiotic biofilm. But then once he followed them through therapy and he started to see a major shift in the bacteria to a very quiet slide, not a whole lot going on there, then that's really what he wanted to do. And he stated that although microorganisms could only be identified morphologically, he decided that those findings would be considered risk factors and therapeutic targets. So what we know about the difference between health and disease is that in health, we're going to see non-motile coccyine rods. It's going to be kind of a boring looking slide, sometimes a still image. But once we go into unhealthy dysbiotic biofilms, we're going to see an uptick in spirochetes, gliding rods, even amoeba and trichomonas, from a gram-positive to a gram-negative environment, aerobic to anaerobic. In healthy slides, we'll occasionally see a white blood cell, but once we get into a really unhealthy slide, we see a lot of white blood cells because those neutrophils are our body's primary line of defense because they produce an antimicrobial effect to help the body decrease the infection. And Dr. Keyes said that periodontists talk about eliminating anatomical defects and monitoring the results with probes. We eliminate bacteria risk factors and look at the results microscopically. How else would we know if we've treated the infection? But Dr. Keyes really had a very different view than the periodontists of his time because the way that he approached this was so radically different. And so, his view would have kind of meant that the periodontists would have to look at some of these surgeries that they were performing and go, wait a minute, I'm just chasing symptoms. I'm not actually treating the problem. And so much of his story, I think, kind of, for me, it reminds me of Dr. Semmelweis in the maternity wards in the 1840s, when bedside fever was really rampant in his specific hospitals and others across the world. And when he looked into it and he realized that the mortality rate among mothers was much higher when the babies were delivered from one of the doctors versus the midwives. And so when he looked into it to try to discover, like, what was the difference? We're delivering babies the exact same. The only difference was is those physicians were were doing autopsies in the morning, delivering babies in the afternoon. So what his conclusion was is there must be something that we're transferring. But this is long before Pasteur's germ theory in the late 19th century, so it was more anecdotal. So his suggestion was, let's just wash our hands. Let's just see what happens, let's wash our hands. It fell on very deaf ears. The physicians just thought that was absolutely crazy, and they didn't adopt it. And he was a very vocal man from what I've read, and so eventually he lost his job, and he passed away. And when he passed away in an insane asylum, it was before anyone ever started washing their hands. And so once germ theory came out in the late 19th century, all of a sudden, lo and behold, that was what was going on. Dr. Peter Attia, has anyone read Outlive? Anyone? Anyone? Oh, man, such a great book. So Dr. Attia talks about that story in his book as well. But what I love about this book in particular is it talks about just the shift that we're having in medicine from medicine 2.0 to medicine 3.0. And for me, the parallels were so perfect for oral health care right now and what we're really able to do. So medicine 1.0 being before science, just very anecdotal kind of guesswork. We weren't able to test it. But then once we moved into medicine 2.0, it was the invention of the microscope, germ theory, and the scientific method where we could test different hypotheses. And once we got into medicine 2.0, we radically changed disease. I mean, we were able to treat infections, acute infections, really well, from vaccines to antibiotics and all that good stuff. What Dr. Attia points out in the book, though, is that what medicine 2.0 isn't so great at is chronic disease. If we think about things like atherosclerosis and diabetes, these are things that go on for decades often before we really intervene. And periodontal disease being the same. I mean, periodontal disease is not only an infection, it's a disease as well. And the early signs and symptoms are so few that until the patient really has a full-blown infection, we don't often do much for it because we haven't had the tools and techniques. And so Dr. Attia talks about, emphasis on prevention, personalized care, and seeing each patient as unique. And so using those same parallels, I'm share with more of those parallels in this presentation. These are mine, not Dr. Attia's, but I felt like it mirrored really well. And so looking at Dr. Attia's 2.0 principles being reactive, focused on acute care and disease-centric, really we diagnose and treat infections as they appear generally in our hygiene operatories. And our traditional diagnostic parameters following this 2.0 method is looking at the probing depths. Are there bleeding point? Is there any debris? Is there any bone loss? But unfortunately, these are reactive. But we thought at one point that any amount of plaque and calculus had the ability to cause disease. So the natural conclusion to that was removal of as much plaque and calculus then should cure disease and prevent it. So using these same traditional diagnostics, then all we need to do is decrease the pocket depths, decrease the bleeding points, whoops, went too fast, and decrease the amount of calculus, and the patient should be better, right? But they're not. Some of our patients look like this. They come in, great home care, minimal plaque and calculus. They're great patients. They come in every 6 months. They've been a patient of the practice for maybe a decade. They refer their friends. They all pay their bills. They're the best patients ever. And we think, easy prophy. And then we get in there, and it's like, ooh, I think I hit an artery or something. Where is all this blood coming from? And so from there, we're thinking, I'm about halfway through my appointment here. What am I going to do? Oh, sorry, I was wrong. You actually need scaling in the presence of inflammation. Oh, wait, I think I'm already doing that. What should I do different? Maybe just work on home care again. What do we do? Or maybe this is a restorative patient. How fast or easy are these types of restorations when it's bleeding all over the place? Really solid margins, really easy to do? Not really. What if this patient had their teeth cleaned last week, last month? Why is there still bleeding? A lot of us think about this when we think about periodontal disease. Lots of inflammation, red rolled margins, bright red mouth, garbage on their teeth. When some of our patients present like this, they're somewhat red, but we think maybe they're a hard brusher. Maybe they have acid reflux. Maybe it's sleep apnea. Maybe they just need some gum grafting and some other stuff. But what they all have in common is profuse bleeding. It's a bloodbath in there. When we think about medicine, our medicine 2.0 and what I like to call oral healthcare 2.0, is there's just limitations because we're looking for the reactions to disease, not necessarily the disease itself. And I'm a big fan of probing, I'm a big fan of all the traditional diagnostic parameters, but it just doesn't tell us the entire story. And so what we understand now is that it's really a combination of periodontal disease causing bacteria, the way that that host immune system is going to react to it, and the overall inflammatory response in the body. So when we think about periodontal disease, this is really what's causing periodontal disease. All those bad bugs, spirochetes, spinning rods, we now know that there's like 60 different types of oral spirochetes. They're all pathogenics. They've been found in the brains of patients. They can cross that blood-brain barrier very easily. So when we think about infections, it doesn't really matter if there's calculus or debris. If they have periodontal disease causing bacteria, they may be pretty sick. So in my humble opinion, I think oral healthcare 3.0, the microscope just allows us to be so much more proactive than reactive. So using these same principles, I mean, we can screen patients every single visit to look at what does their biofilm look like. Is there anything swimming in the plaque that we should be aware of? And then we can understand each patient's individual immune system. Does this patient have lupus or Crohn's disease or psoriasis? That's an inflammatory condition. On top of that, are they taking an immunosuppressant drug to decrease that immune response? Now it's like they have a double whammy because they not only have an inflammatory condition, but we're kind of trying to push down their immune system so that it doesn't react to that. Well, if those patients come in contact with periodontal disease causing bacteria, they can get sick pretty darn easy. So if we can alert our patients to all these risk factors and take a slide, be more proactive. If patients see those squirmy wormies, they're more inclined to do whatever it is that we recommend. So following Dr. Kai's modulated microbial periodontal therapy is what I recommend and teach. It's really no different. The only change is that I supplement it with a salivary test as well so that we can find out what pathogens are causing that infection. So Dr. Kai's, he would do that meticulous clinical medical dental exam and also take a slide. See if there's any periodontal disease causing bacteria on the slide. From there, it was going to be educating the patient about what he saw, what that means for their treatment. Overall treatment always was going to include antimicrobial agents and meticulous home care. He was a big fan of peroxide and baking soda and brushing it into the gums and really disrupting and disorganizing that biofilm, which is so important, not just brushing and flossing. Because if a patient has a very dysbiotic biofilm and we're just brushing and flossing, we're essentially just smearing around the biofilm. We're not penetrating that biofilm wall or disrupting or disorganizing those bad bugs. And so after that, Dr. Kai's would get them back and reassess. His was about 2 to 4 weeks. Was the slide clear of white blood cells or other bacteria or other microorganisms that cause periodontal disease? If it was clear, he would get them on a maintenance schedule. But if it wasn't clear, that's when he was going to do modulation, potentially adding a systemic antibiotic, adjusting their home care, figuring out what their interval needed to be. And then their recare was always going to be based on what it looked like each time, what the patient was able to do for themselves at home. What does that patient's medical history look like? So no longer a one-size-fits-all approach, but just recommending what the most optimal care is going to be for that patient. I love the microscope because it shows us what our eyes often can't see. I've had plenty of patients that look absolutely fabulous, all to find out that their mouth is swimming with infection. Sometimes you'll take a slide on patients that look absolutely fabulous, and their microscope slide is like an all-out battle going on there. And if we can treat and really identify these infections in those early stages before any signs and symptoms, we're being far more proactive than reactive. I've had patients that everything looks great. We go through therapy. They do everything they're supposed to do. I do everything that I know to do, and it still doesn't get better. Well, what a great time to refer to their physician and say, you know what, we've done everything that we can do. I would like you to move forward with more blood work. Let's do more investigation. What's going on with their immune system? I've had patients that have had leukemia and other systemic issues that were altering their immune system so they weren't able to fight off this infection. So at risk of oversimplifying the new understanding of periodontal disease, we now understand it's really the host immune response in relationship to those periodontal disease-causing bacteria. So all of us could be coming in contact with bad bugs all the time. That doesn't mean we're sick. We may all have the bacteria in our mouth right now that causes strep throat, but we don't have strep throat. If we have enough good bacteria, great immune response, that's really what we need. And so take a person that has some bad bugs. Well, then if they get biofilm accumulation on any area, let's say it's a subgingival surface, and they're not able to clean it out, maybe they're just getting too busy or they're stressed or whatever the case may be. If the biofilm sits there for too long, the immune system goes, we need to get this out of there. So we have that inflammatory response. That acute inflammatory response is good. bringing the white blood cells. Also increasing that gingival curvicular fluid. The mouth is saying, flush out the garbage, get rid of it. But unfortunately, those bad bugs, they don't want to be gotten rid of. They want to stick around and make a nice home for themselves and all that kind of good stuff. Well, if the body is naturally going to bring more and more and more white blood cells to the area. So unfortunately, what happens then is that we have this nice tight gum tissue getting swollen, 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 and then the gums are leaky and permeable. So if you have bad bugs in the body, those bad bugs just simply hitch a ride through our 60,000 miles of blood vessels in our body. So oral pathogens cause systemic problems because they don't just stay in our mouth. And one of my favorite things is what Dr. Sindelar said a long while ago. When we look at the root cause of periodontal disease pathogens, the oral systemic connection becomes clear. Periodontal disease doesn't crawl up through your nose and into your brain. Periodontal disease does not sneak across the placenta barrier and cause pregnancy complications. Heart disease is not periodontal disease located in your chest. Oral is systemic because of the pathogens. He goes on to say that what research is finding is not that periodontal disease causes systemic disease. It's that the pathogens that cause periodontal disease may also contribute to systemic diseases. He said that nearly a decade ago. We now know that at least 57 systemic diseases are related to periodontal disease. This is one of my favorite pictures because it shows the specific pathogens that are related and associated to these diseases. Now, of course, when it comes to using the microscope, we don't know which pathogens are there, but Dr. Kai showed us that we know morphologically that certain bugs are not part of our good bacteria. So following what Dr. Kai is saying is we can look for low risk, moderate risk, and high risk slides, and then from there we now have the availability to take a pathogen test to see what bacteria are lurking in that patient's mouth. So let's look at some slides. So when we see a low risk slide or a healthy slide, it's going to have low volume, low motility. There's not going to be a whole lot going on. Sometimes the low risk slides look like a picture, not even like a live video. So they're kind of boring. It's great. We all want boring mouths like that. But once we move into a moderate risk slide, that's generally when we're going to see a pretty big uptick in the amount of spinning rods. So it's not a frantic looking microscope slide, but there's definitely some things going on in there that we want to intervene. And in the most perfect world, this is when we intervene every single time. We can become an investigator. Has that patient all of a sudden been not getting enough sleep? Do they have sleep apnea and they just stop wearing their CPAP or their oral appliance? Did they stop using their water pick? What are the different things that we can do to modulate and modify now to ensure that this doesn't grow up to become a more serious problem? When it comes to high-risk slides, there's lots of different looks to high-risk slides. So we'll start with my favorite, the spirochete. So being 60 spirochetes, all being pathogenic, that spiral shape allows them to not only move through plaque and saliva, but all through cartilage, very easy. Spirochetes have the ability to live in multiple hosts in one lifetime. So if I start dating somebody and they have some spirochetes and we like each other, well, they might be sharing that spirochete with me. And then if I have a child and I'm kissing her and sharing food and drink, I'm passing that bacteria to her. So it's all about each individual's immune response, whether or not they're going to get sick. And so T. denticola is often found with P. gingivalis. Some researchers believe that where one is, the other is. They have the ability to cross the blood-brain barrier, interfere with clot formation. Spirochetes overall are just bad. So when it comes to motile rods, so motile rods I think can sometimes be a tricky one because we'll see a lot of different rods in patients' mouths. Short rods, long rods, filamentous rods, all different shapes. In general, the more motile they are, the more pathogenic that they are as well. So when we see motile rods, they're flipping and flopping all over the place. That movement, again, allows them to move easily through the fluid, the saliva in our mouth, and through plaque. Amoeba, Entamoeba gingivalis, a protozoan parasite. So this is that little guy right there. That irregular border is what we look for. And as you can see here, there's a white blood cell inside of it. My friend Lisa says that they're like Pac-Man. They just go around and eat those white blood cells. And so if we look closely on this slide as well, this is actually remnants of white blood cells right there, and those spirochetes are just tearing it apart. And there's some clock arm rods up there, all kinds of volume activity, even some white blood cells over there. So Entamoeba gingivalis loves an inflamed mouth. It's like going to the buffet at the casino here. There's just tons and tons and tons of food for it. The thing with Entamoeba gingivalis too, though, is that it evades the immune system. So when it comes to the amoeba, if we don't disorganize that type of bacteria and all this biofilm, we can throw antibiotics and antimicrobials at it all day long. But if we're not penetrating and disrupting that biofilm wall, it can be very resistant. Oh, Trichomonas tenax. I think they look like little mice. And so they're an anaerobic flagellin protozoan parasite. So they are transferred just like the other bugs, mainly parents, partners, pets, sometimes contaminated food and drinking water. The thing with them, though, is that their byproducts actually alter the immune response, so they promote replication of other pathogens. Bless you. And so whenever we have this dysbiotic of a biofilm, there's such a huge shift in those bad bugs. In some periodontal infections, the bad bugs outnumber our good bugs by 3 times. So if we don't help our patients, their immune system is just too taxed and unable to really fight off these serious infections. So white blood cells, our body's first line of defense. So when we see slides that have all these little circles on them, I like to look for the dancing dots inside, those little cytoplasmic granulars, and all this area, granulars. All these area here are these little tiny circles. It doesn't even, it kind of more looks like plaque mass than it does look like white blood cells, but these are just clusters of white blood cells. So those white blood cells are going there because they elicit an antimicrobial effect. So they're trying really hard to kill and get rid of all those bad bugs. But unfortunately, our bad bacteria evolved with our good bacteria, so it knows how to evade our immune system. So it's sneaky like that. And so we can even see high volumes of white blood cells before there's any destruction. So a few takeaways, there's many more than this, but just a few takeaways when it comes to pathogens and our immune response. So pathogens release leukotoxins, which is going to poke holes in our white blood cells, which means that they're going to die. So our first line of defense is automatically taken out because of those leukotoxins. Production of collagenase. So again, we're going to break down that gum tissue because of all this pathogen load, because there's such dysbiosis. And then fibroblast inhibiting factor. So it stops the body from even being able to rebuild and regrow. So this inflammatory response just kind of feeds on itself. This slide over here has lots of cool stuff in there. So we've got some corn cob effect here. We've got an amoeba over here. We've got some white blood cells. That person kind of had it all kinds of infection. I think this person was in their 20s. So when should we take a slide? Barbara, when should we take a slide? We can take one every appointment, absolutely every appointment. So if you've never taken a slide before, we don't start taking a slide on every patient, but we start with a couple patients at a time. New patients are great. A patient that you see with any type of inflammation, it's such a great teaching tool. Imagine seeing any of these little creepy crawlers in your mouth and how you would feel. You would be like, what do you need me to do? I will do it whatever. Do I need a water pick, perioprotect trays? Give me the gamut. I will take the kitchen sink home with me. Let me know. So what we're really looking for on these slides is the slide healthy? If it is, great. Continue on your merry way. Keep doing an awesome job. Don't quit doing what you're doing. But if we see that moderate risk slide, it's an awesome opportunity for us to stop and to become an investigator, figure out what's going on. So not just like, oh, probably just brush and floss more and we'll see you next time. No, like what do we need to do to pivot that so that we're not promoting dysbiosis? If we see a high-risk slide, it's a sure sign that we need to intervene right away. Because if we don't intervene, then it's probably just going to get worse because, again, in these very serious infections with high-risk bacteria, the bad bugs outnumber the good bugs by at least 3 times. So these are very serious infections. So let's look at some case studies. So this young lady, her name is Grace, and she was so fabulous, she let me take pictures and videos to use for educational purposes. So Grace had shared that she had recently been to the orthodontist and that she felt like her gums were pretty swollen, but the orthodontist wasn't too concerned about it, and so she thought that must just be normal with braces. And so I said, well, I don't really, think it is, but let's go ahead and take a slide and let's clean your teeth and let's just do all the things. So that's what we did. And so the next video, I'm going to see if the audio plays. I'm going to use my speaker. And so I'm using an older style of microscope in this video, so it's a little bit hard to see the creepy crawlers on here, but you'll kind of get the gist of it. And the conversation doesn't even have to be this long that I do with Grace, but you'll notice the look on her face is real time, live time, like, oh my goodness. All right, Grace, so today, because I saw that inflammation in your mouth and things had definitely changed from last time, and nothing's changed for you that you're aware of. So what we're going to look for on the microscope is to see if there's any pathogenic bacteria causing the inflammation that I was seeing today. All right, let's get this into focus. So what we're looking for here is different shapes of bacteria, because we know that different shapes of bacteria can be pathogenic in nature. All right. Well, this definitely explains why I was seeing such a change in your mouth. Crazy, right?
That's my mouth.
It is. So, what we look for is good bacteria, but also the high and moderate risk. So what you have going on here. So the stuff that's not moving is plaque. So that's just like dirt. If you're working on your car.
That's good health. Okay.
Totally. Hands get dirty, they don't get infected. Get a cut, something like that, could be a different story. So what you have are a lot of these little snaky looking guys in here. Those are all spirochetes. Spirochetes are a bacteria that likes to live inside your gum tissue, not just on top of it. Just like these rods here, these hard lines that look like sticks on there are all rods. They're also an anaerobic bacteria. So once we take them out of your mouth, they die pretty quickly, which is why they're kind of hard, like they're not really swimming around like the spirochetes. Can still live in oxygen for a little while, so that's why they're swimming around on there. Let me make sure this is in good focus there. This globe right here is a white blood cell, so that's an indication that your body's trying to fight off this infection, but definitely by the whole volume of spirochetes you have, it's just overwhelmed your system. These globes right here are air bubbles. That's my fault, nothing to worry about. This is just more plaque mass. It just kind of glows because there's a lot of oxygen within there.
And those are like spirochetes, right?
Yep, all those little snaky things are spirochetes. So definitely some infection that we need to use medicine to treat it, because what we need to do now is to help your body decrease that overall pathogen load so that your immune system can take back over and get you back healthy.
Okay.
Super scientific explanation for her there. My favorite way to explain to a patient what I'm seeing in their mouth, especially when it comes to all that stuff, is think of these bacteria like termites in the foundation of a house. They live deep down inside the gum tissue, not just on top of it. That's especially important when our patients are doing everything. I mean, we'll have so many patients that say, I'm brushing, I'm flossing, I'm coming in here all the time. What is going on? What happened? And it's like you came in contact with some bad bugs and your mouth got sick. Your immune system wasn't able to fight it off. So let's look at a few case studies. So let's pretend this is your patient on Monday morning, and now you have a microscope. So 33-year-old woman comes in. She's unsure when her last dental visit was. She's diabetic and she's taking metformin. You take her blood pressure, it's 130/85. She was completely unaware of high blood pressure. Her main reason that she came in is that she has a deteriorating tooth on her lower left. She's not really sure what's going on. She can feel some roughness on her lower anteriors, and she started to notice that her front teeth seem to be pushing out a little bit, and she's getting more of a space, and they also feel almost a little bit loose. Her main goal of what she wants to achieve by coming back into the dentist is to get the lower left tooth taken care of, to figure out what's going on because it's starting to get sensitive, but she wants to have the straight teeth that she used to have. So you may think to yourself, wonder how straight those were. So I asked her. I said, well, tell me a little bit more about your smile before. And she's like, well, I always had a little bit of a space between the two front ones, but now she's like, it's like they're flaring out. So next step was to gather the rest of the data. So I pretty much knew right away by looking at her and taking the photos what was going on, but we needed some self-discovery. So I took a full set of x-rays. Her overall x-rays were generalized horizontal bone loss, 5 and 6 millimeter pockets throughout, but then she had this huge defect in the front. And I was like, well, no wonder you're getting more of a space, mobility. I'm thinking, you are 33 years old with a 9 millimeter pocket on one of your front teeth and like a 6 on the other. And so next step is to take a microscope slide, because this is not somebody that I would want to put in orthodontics or any kind of aligner system. And so this is her microscope slide. So this is the one that we looked at a little bit earlier on that other slide, but as you guys can see, it's just an all-out war in there. And remember, I mean, she has diabetes as well, so we know that patients that are diabetic can be up to 3 times more likely to lose bone faster than somebody that's not diabetic. I mean, it's such a two-directional relationship. We can really see the battle going on with those spirochetes. They're just having a feast right there, tearing apart that white blood cell. Amoeba kind of growing in there, all these white blood cells down here as well. And within the plaque mass, we'll also see a lot of activity in there too. So whenever we're looking at slides, we just go to that fluid space to see what's swimming around and what's chilling out in there. And she had a lot of spirochetes. The next step was to take a salivary lab test. And so there's several different tests available right now. My personal favorite is the paper point test, because you can take the paper point and put it all the way to the base of the pocket. We know that the most dysbiotic biofilm is going to be in the deepest pockets, simply because it doesn't get disrupted as easily. And so we want to get that attached biofilm, because that's going to be the most pathogenic. And so where I have these little red, or these
blood marks here, is that those 4 pathogens specifically are related to diabetes. So she had 9 of the 11, but not just 9 of the 11. We only go to 10 to the 7th here. I mean, she's like topping the charts. So a super, super severe infection. And so the next step is full mouth gum tissue therapy. So what in the world is full mouth gum tissue therapy when you see all these bacteria? So following Dr. Kai's method, it's really using antimicrobials, disrupting and disorganizing that biofilm. Not just brushing around the gum tissue or using your ultrasonic, but full mouth, disrupt all of it, teach her exactly what she needs to do at home. Now, this particular test is MicroBlink and DX, and they will give you a suggestion for antibiotics. Not everyone needs antibiotics. I mean, it'll put out antibiotics far more often than is needed, and it's up to the doctor's discretion whether or not you ever want to use them. In this situation, the doctor did elect to do metronidazole simply because she had had periodontal disease for so long. She was diabetic, and she had a 9mm defect. So really, the goal was just to clobber this infection. So home care. So I always send my patients home with a home care sheet that tells them exactly what I need to do. So show, tell, do in the office like we learned in school, but then also this just has some QR codes on the bottom so they can pull up a YouTube video of me showing a patient how exactly they need to water pick, what they need to do to disrupt and disorganize that biofilm. Tongue scraper, the whole works. She could have benefited from perioprotect trays, but this practice didn't have those. But in those deep pockets, we need to do something to get subgingival. Now, what we're going for when we bring that patient back for SRP1, SRP2, flushing all that mouth out, doing all the things that we do, is we really want to see decreased volume, decreased motility, and the overall bacterial load. It may not be perfect, and some patients have very serious infections that they may have even had for decades. So you may not see complete eradication of the bacteria, but you do want to see decreased volume and decreased motility. So over here we can see a couple rods dancing with each other. So her after is not perfect, but clearly better. So even to an untrained eye like our patients, they can see like, hey, I've got a lot less squirmy, wormy stuff going on there, so I'm headed in the right direction. So for her, we took another photo. I love intraoral photography, especially a retracted photo, because it just shows that patient so much more. Patients are used to seeing their teeth and smiles, but not everyone has a gummy smile, so they don't always see what it actually looks like when you take retractors and pull their lips back. We also took a follow-up test. The benefit of taking a follow-up test and a before test is you objectively know, did you decrease the overall pathogen load? So you can compare. We started with 9 periodontal pathogens and we're down to 4. Now it's not perfect. FN is still a little bit high, but I'm not really too worried about it. It's looking pretty good. FN can be a tricky bugger to really get down. And again, some of these bacteria take some time to really make a big headway with. For being 3 months and her having diabetes and everything was pretty incredible. Now, what I don't ever do if I have a vertical defect is probe right away. I take a PA. Because if the bone's going to regrow, I don't want to stab the connective tissue, ever. So the first thing I do is take a PA, how's it looking? And for her, within 3 months, the bone's already regrowing. And I was like, wow, amazing. I think I was more excited than she was. And so I was like, okay, keep doing what you're doing. It's working. The microscope looks good. Your lab test looks good. Your x-ray looks amazing. So we kept tracking her through time, 9 months, 12 months. And so at 12 months comparison, I mean, no grafting. I didn't have a laser in this office. It was antimicrobials, full mouth Cavitron, full mouth every single time that she came in. And she was diligent with her home care. And so definitely more of an area where I'm like, hey, I think doc would definitely consider some orthodontics, moving into that direction, and keeping everything really healthy. The interesting thing about her case is that after I initially saw her, she looked at her microscope slide, we looked at her medical history, talked about all the things. She canceled on me multiple times. And I'm thinking, I just showed you that you could lose your 2 front teeth. I mean, I'm not shy about it. It's like, I'm very concerned about this infection. We need to intervene. And so finally when she came in, I was like, hey, what's going on? We really need to treat this aggressively. And she said, well, my identical twin sister had to have open heart surgery twice. And she had multiple organ failure. And so, I mean, split open, heart surgery, the whole thing. And I was like, oh my gosh, like that's crazy. So by the time we get her like through treatment, she's sharing with me updates on what's happening with her sister. So she's got all these specialists and finally gets out of the hospital. And what they determined was the cause of all this multi-organ failure was an infection around her wisdom teeth and the gums. So I thought it was pretty interesting that while one sister's literally fighting for her life, the others
potentially losing teeth, but who knows what else is going on, the cascade of events that's happening there. It's pretty crazy. Next case study is not mine. It's my friend Sarah. Sarah she works at an all hygienist practice in Colorado, and they are just fabulous. They serve a lot of the underserved population, and they take Medicaid. Most of their patients that do SRP need predeterminations. These patients do lab tests. They have guided biofilm therapy. They have lasers. They have everything, and these patients do what they're recommended because they get it. And so for this particular case, this is one of her recent ones, and I just thought it was so great, so I asked her if I could share it with you guys. So she was a 32-year-old patient, came in. She was unsure, just like my last gal, of her last dental cleaning. Diabetic, taking on an insulin pump since 24, taking on Trulicity, A1C of 12. So Sarah was like, whoa, what is going on there? And she said, I've been working with my physician for a while. We're having a really hard time getting my A1C down. I know I need to lose weight and do some of these other things, but man, I'm pretty concerned about it. So what brought her in is that she thought that her diabetes was affecting her gums. She was noticing recession on the lower left and bleeding every single time she brushed her teeth. So doing the whole workup, x-rays, took her microscope slide. Pretty frantic slide. This one's like so thick it's almost kind of hard to even see everything that's going on. But she had, lots of white blood cells, spirochetes in here that are a little bit tricky to see, a lot of spinning rods, just frantic looking slide. So, was her diabetes affecting her gums? Probably, yeah. Took her lab test. She also had 9 of the 11, not the exact same 9, but all 5 of the pathogens that are related to diabetes this woman had. So definitely made sense why all of a sudden she was getting a lot of bone loss. And it's interesting because some patients will have just like one major vertical defect or a certain area that all of a sudden gets recession, but it doesn't always affect the entire mouth. Rest assured, these infections are in the entire mouth, whether it's a 2-millimeter pocket or a 10-millimeter pocket. The bacteria doesn't really care if we do, scaling and root plating on 1 to 3 teeth. It's not gonna say, well, let me just stay over there now. So her therapy, because they had guided biofilm therapy, lasers, ultrasonics, the works. The doctor that they work with in terms of all their restorative dentistry and whether or not they're going to do systemic antibiotics did elect to do metronidazole with her because of the severity of her infection. And home care was all the things. Show, tell, do, come in, full mouth flushing every single time during her SRP. And by her follow-up, it was low volume, low motility. Looked absolutely incredible. And so before and after photos, super red gum tissue, really, really angry, to pale pink, looked so much better. But I mean, couldn't believe. This is like 2 months later. She went from 9 to 3, all below threshold, which is pretty darn good. I mean, just telling y'all, that's like really good. The coolest thing though about her case is that right before she came in for her follow-up, she saw her physician and checked her A1C and it was down to a 10 in just less than 2 months. This is something that she'd been working on with her doctor for, I don't remember how long Sarah said, but like a year. And within 2 months of periodontal therapy, she was able to get her A1C down to 10. That inspired this woman to really just take a look at her health and think like, what else can I do? I really probably need to get on track because her A1C, her diabetes, all the things, it was just, she knew she needed to make some lifestyle changes. So she decided that she was gonna get gastric bypass. She lost 25 pounds, her A1C dropped to a 7. And then the last that Sarah had updated me that she had lost 60 pounds and her A1C dropped to a 6.9. So all starting with just getting her gums healthy, getting on the right track, spending time with her hygienist. When she went to the, important note, when she went back to her doctor to get the A1C and then it was a 10, he was like, what are you doing? And she said, lots of visits to my dental hygienist. And that's exactly what it was. So I wanted to leave time to open up for questions here. So ask me anything. Yes? Yeah, so that's a great question. The question is what do I think about oral DNA? So oral DNA and MicroBlink DX are a very similar test. They're both ran at Access Genetics. The main difference is one is swish and spit and one is a paper point test. So they're both great tests. They're testing for the same 11 pathogens. It's just what type of delivery method do you prefer?
How many points do you use?
The paper point test has 5. So what a lot of people will do is they'll just pick 4 pockets and then they'll do a tongue. Yeah, you want to pick the deepest pockets. Yep. And if there was an implant patient, then I run the implant. I mean, some patients that are, if they're an all-on X or something, you would just do around their implants, so it doesn't really matter. Yep. Yep. The most dysbiotic area.
What's the turnaround time for these things?
The turnaround time for both of those, if you overnight ship, so you have the option to bulk ship them, or just every single time you take a lab test to send it in, and it's about 7 days. And then you get your results via a portal. So you just log into the portal and it'll have your patients in there. Yeah, both test costs have the same cost, and they're $109. Is that right, Kathleen? Anybody else? There's got to be something. All right.
Patients who have moderate advanced perio, but their slide comes out clean.
So what do I do with a patient that has moderate to advanced perio? So tell me more of the scenario that you're thinking with the patient, like moderate to advanced, so meaning they have like 8 millimeter pockets, but they're not bleeding, and they're potentially stable pockets?
Yeah, you can say yes. Yeah, they just, I don't know, they could be bleeding, they may not be bleeding. Let's just say they're bleeding.
Yeah.
But they have no pathogens.
Then I would take a lab test to investigate further, because there's something going on there. So whether it's bruxism or there's got to be something else happening to erode the bone away, because we now understand that recession isn't just Mother Nature.
And how much of a conversation do you have around nutrition?
Quite a bit. So the way that I generally work with patients is we take one step at a time. We address one thing at a time. Sometimes if we throw absolutely everything at somebody, this is what we need to change your diet. You need to get on 4 different types of rinses and all these different things. And sometimes it can be really tricky. So what I work with is, for example, like when I volunteer and locally, some of those patients maybe brush their teeth once a day, if that. So for them, my only goal is to get them brushing even better and to start using a water pick just once a day. I don't even care what time, because their value on it is just something different, that maybe they were just not raised that way, so it's just not something that they're able to do. So somebody like that, I may say, you're diabetic, you have all these other things, we're going to get there. But my goal is to work with them for the long run. So once we get them at least stable with brushing their teeth properly at least once a day and using a water pick and disrupting and disorganizing the biofilm, and if they're seeing the microscope every time, they're more apt to go like, oh, it's not just their word against mine. It's not just, oh man, it wasn't bleeding until you poked it. It's not that conversation. And so from there, as we work together and if they get on track with doing the things that I'm recommending, every time I'm just going to add a little bit more and a little bit more and a little bit more until we continue to move in the right direction.
Okay, have you guys thought about using or do you use iodine or anything like that to kill the bacteria while you're doing treatment?
Yeah, so that's a great question. So the question was, do I use iodine with treatment? So I work with a lot of different practices, and everyone kind of has some different medicaments. So some people use ozone, from water to gas to all the different things. But yes, iodine is great. Yes, I personally don't feel like there's just one thing that works.
No, but
yes, absolutely, yes, 100%, yes.
What do you recommend to add to the water pick chamber? Do you have anything that you recommend?
So the water pick, yeah. So the question is what do I add to the water pick chamber? I mean, my personal favorite is like PerioScript. It's a concentrated rinse. It's all natural, organic. There's no alcohol in it. It tastes fabulous. So patients like to use it. It comes with a pump, which for whatever reason, the ease of use, it also. Everything that makes it easier and less restrictive, like the patient will do it. So I've had the best luck with that particular rinse. Doesn't stain their water pick or anything, and it's very affordable. You can buy it in bulk for your practice at a discounted rate. The patient can turn around and buy the next stuff on Amazon if they want.
Would you say the majority of the cases who don't use their water pick routinely can clear up the slide?
Yes. The question was if a patient doesn't use a water pick, can they clear up their slide? They could also do like PerioProtect trays or something like that, but the main thing with biofilm that we understand is it's disrupting and disorganizing. So my terrible analogy here, am I okay on time, Barbara? Okay. So it's like if this was the tooth or the surface in the mouth, and this is the biofilm. So it's got those finger-like projections. And then it's got that mushroom cloud that we learned about in school. The bacteria is inside being housed in there. And remember, it doesn't want to go anywhere. It really likes our mouth. So it's a great environment. So basically, it's stuck to the tooth, stuck to the root surface, wherever the heck it is. Brushing and flossing is just going to make it fall off, and it may just attach someplace else because we didn't disrupt and disorganize it. So we must penetrate the biofilm wall. Or even if we threw systemic antibiotics at it, it wouldn't matter. It doesn't matter if we use the best antimicrobials. It's not always going to get rid of it. So we have to find something that's going to penetrate that and disperse and disorganize constantly to give our immune system a fighting chance. Anybody else?
How are you using the PerioProtect trays?
So PerioProtect has a gel that you get with it. Yep. So you take impressions or you use your scanner, custom make them. They fit over the gum tissue, and then they have gel that you just put one slip. And then during active therapy, they would use them for 15 minutes twice a day, and then for maintenance, usually once a day. And a lot of patients love them because slowly but surely, as a side effect, it'll whiten their teeth. And everyone wants whiter teeth. And it's easy. Exactly. The path of least resistance. All right. Cut me off, Barbara. Cut me off. If you guys,
The speakers forum.
yes. And also, if you guys want to see what's living in your mouth if you don't have a microscope, come check it out at my booth.
Yay. All right, the microscope.